Hi there, this is the last installment of Pharmacodynamics and Pharmacokinetics of anti-cancer drugs. I'm just going to go over a few pharmacogenomics, which basically, few that I know about. Dr. Schneider is probably going to go into more detail on this. But I'm going to talk quickly about 4 enzymes that are responsible for different chemotherapy drug metabolism. And so if you are genetically pre-programmed to have less of these enzymes around, obviously your clearance is going to decrease, which is going to increase your concentration, increase your half-life, and increase the possibility and probability of toxicity due to these drugs. So it's important to know ahead of time if your patients have any of these genetic predispositions that will encode these mutations that will encode for less enzyme to be present that metabolize these drugs. So the first enzyme is thiopurine methyltransferase. It's responsible for the metabolism of the thiopurines, which include 6-mercaptopurine and pure ethyl. And so there's 3 variants that will have higher rates of toxic effects from these drugs. And that's if you have the 2, 3A, or 3C variants here, you can see that you are going to be at higher risk for toxic effects. The 3C is the most severe and causes severe bone marrow depression. It's most common in patients of Asian or African descent or African American descent. So especially if you have a patient that's in one of those 3 racial groups, you're definitely going to check to make sure that they don't have this variant, because these drugs may not be able to be used, or they may be able to, and I don't know what the protocols are for these, but sometimes you can use them, but you just need to decrease the dose rate and increase the dose interval because the clearance is decreased, or maybe the drug is contraindicated if they have this variant because they just can't metabolize the drug. Another enzyme that might be genetically programmed to be absent or in much lower quantities is dihydropyrimidine dehydrogenase, or DHYD. This is responsible for the metabolism of 5-FU, which is a commonly used chemotherapy agent. This was first brought to light by, again, that same group at St. Jude's with Bill Evans, a pharmacist. If you have the 2A variant here, patients are at great risk for toxicity. He found these patients were actually dying and wanted to understand why these patients had such a severe toxicity, and found this variant in their genetic makeup, which encodes for less of this enzyme to be made, and therefore putting them at risk for 5-FU metabolism. Again, you want to make sure that the patients don't have this variant before you start dosing 5-FU. Cytidine deaminase, same idea. This converts cytidine to urididine, and it's used to metabolize rather than metabolize. There's a B missing there, I'm sorry. Of anti-cancer analogs like gemcitabine and cytarabine. If they're the 2 or 3 variant, there will be a decrease in the clearance of these drugs. And last but not least, UGT is responsible for conjugating and metabolizing irinotecan. Irinotecan, I think is how you say it. If you have the 28 variant, we have a decreased expression of that enzyme, and these patients go on to have profound diarrhea and leukopenia. So there's 4 enzymes to be aware of that you need to be on the hunt for to get the genetic makeup of these patients before you go ahead and dose them. I'm sure Dr. Schneider will give you more detailed information about this. Maybe he already has. All right, in summary, we know that therapeutic drug monitoring can help provide individual dosing for some drugs, which will help improve efficacy and toxicity in treating cancer. We know that we do give creatinine clearance-based dosing of some drugs like carboplatin. So if it's cleared by the kidneys and we have renal impairment, you can make adjustments, which we do for most drugs. But is really going to be important in these very toxic chemo drugs. We know that therapeutic drug monitoring improves the safe use of both methotrexate and busulfane, and it improves the efficacious use of these drugs. Why don't we use it more often? Good question. Is it too hard? Do physicians not feel comfortable with it because they haven't been doing it enough? I can tell you, when I look at this data, if someone I cared about or I were needing treatment with these drugs, I sure would want them to be dosed individually for me. Is it too hard? Yes, it's tough to do. Is it something you should be doing once a year? No, you should kind of be specialized in it and make sure that you're doing it every day so you're really good at it, instead of thinking, how do I figure out area of the curve again? That would make me nervous if I were a physician or patient. So, but it surely shouldn't be beyond any pharmacist that decides they want to take this on. Also, I wanted to show that there is improved outcomes and feasible methods for these drugs as well. All right, thank you for listening to these. I hope you found them helpful. All right, take care. Good night.